Hey everybody, welcome to How to Give Bedside Report, the Medical Surgical Edition. Now I've created a system behind how we give bedside report in the medical surgical units. Typically, we have a set format behind how we give report, and it's set up like this so that we give all the most important information, all the pertinent information to help the nurse prepare for their shift. Now, all the information in this PowerPoint is pretty much the framework you're going to use to give bedside report, but it's not limited to everything inside this PowerPoint. So if there's more information, more details that you need to give your nurse, make sure you give them that. But this is just going to provide you a framework, a baseline, a foundation to giving bedside report on a medical surgical unit. So let's get to it. So let's go over some key elements behind giving a good bedside report. Now, you guys know that the purpose of giving bedside report is to hand over care to the next nurse. When you're handing over care to the next nurse, you want to give a complete and concise overview of the patient's care. How did your day look like? Is it going to look like that for me? What does my shift look like as the nurse who's going to be receiving the patient? You want to give enough information to prepare that nurse for whatever that patient may have for that day. And it helps the nurse know whether this patient is going to be more labor intensive or less labor intensive. So you want to give a complete overview of that patient's care. In terms of your format, we use a systems approach to discuss all the pertinent information of the patient's care. So what do I mean by systems approach? We're going to go through neuro, cardiac, respiratory, GI, GU, skin, and musculoskeletal. And all of this stuff doesn't need to take so long, but there are key elements that you need to touch on for every single patient that you give report on. Now, I will say this, a good bedside report should be done at the patient's bedside, but you'll find that a lot of nurses don't do that. And it takes a while to, go from patient to patient, but it is really good to have both nurses eyeball the patient before you give handover care. Say, for instance, something is happening, making sure the drips that they said they hung are hung. So doing a good bedside report should be at the patient's bedside, but you'll realize that a lot of med-surg nurses don't do that. And lastly, your bedside report shouldn't take more than 10 minutes because you're giving report on 4 or 5 patients on a medical surgical unit. So you don't want to go too in depth. A lot of the information, the next nurse can find it out, but you want to give them enough information to prepare them for their day. So 5-10 minutes is a good amount of time for each patient. Now, anytime you give an intro to the report, you want to mention all these key elements first: the name, the age, the gender, the code status, the next of kin or the healthcare proxy, any allergies that stand out, and the isolation precautions. This doesn't need to take too long, 20 to 30 seconds max to say all of this. Now, for the allergies, if there is an extensive list of allergies, you don't have to mention every single one. You can just say they have an extensive list, and the nurse can take initiative and check those allergies on their own. Another bonus is to talk about why they're on isolation precautions. So if your patient is positive for C. diff and is on contact plus isolation, it's really good to mention that because it kind of sucks as the nurse receiving the patient to walk up to the door and see an isolation precaution and then have to go back to the computer and find out, okay, why are we on isolation precautions? Should we even be on it? So talking about why they're on isolation precautions is a bonus point when you're giving report. All right, here's an example of a solid intro to giving report. So Sandy is a 77-year-old female admitted with left lower lobe pneumonia. She has a past medical history of AFib and she's on warfarin. She has coronary artery disease, hypertension, type 2 diabetes, anxiety, and depression. She's a full code with no known allergies and she lives at home with her husband Neil, who is her healthcare proxy. Now, you want to be specific about whose name is listed on the healthcare proxy, especially if you're giving report to a day nurse. During the day, nurses tend to get a lot of calls from family members checking up on their loved ones, which is perfectly fine, but you don't want to give too much information to too many people because number one, if their name is not listed in the electronic health record, they shouldn't be receiving information. So being clear about who's listed as a healthcare proxy is a bonus point. If you don't know, the nurse can check it up on their own, but it is a bonus to let them know who the healthcare proxy is. Now, after you've given your 30-second intro, you've talked about why the patient was admitted, who the patient is, and how they were admitted. You want to talk about the admission. It's a brief synopsis of why and when the patient came in. The best way to find this out is the doctor's admitting history and physical. You don't have to reinvent the wheel. You don't have to look and put the pieces together. Reading it just right off the doctor's H&P notes is the best way to talk about their admission. I also like to mention when they came in so that you know how long they've actually been there, whether it's been 3 days, 7 days, 120 days. Talk about why they came in and when they came in. So an example of an H&P would look like this. Patient presented to the ED from home on 7/4 via EMS for difficulty breathing. She had a fever of 103 and she was coughing with some nausea and vomiting, decreased appetite, confusion, and weakness for the past 3 days. Her husband states that Sandy is not normally confused at baseline. So upon arrival, the EMS found her O2 sats to be in the 80s on room air. They placed her on 4 liters nasal cannula with improvement to the 90s. On arrival to the ED, she was given a 500 ml LR bolus and nebs and started on IV ceftriaxone and erythromycin. She also had a CT of her chest done, which showed left lower lobe consolidation. So she's being admitted to this floor for treatment of pneumonia. And that just gives you a nice brief synopsis of why the patient was admitted. As I mentioned in the beginning, you're going to use a systems approach behind giving report. So you're going to touch on neuro, cardiac, respiratory, GI, GU, skin, and musculoskeletal. This doesn't have to be in depth. You're just going to talk about the key aspects of that system. And it's supposed to prepare the nurse for how their shift may look like, what does their patient look like, how does that patient present. You also want to include anything abnormal within that system and what interventions you did for that particular finding. First on the list is your cognitive, neuro, and behavioral assessment. Now, this doesn't need to be too extensive, but it needs to at least let the nurse know where the patient stands at baseline or where they are at during their last shift. Now, for this particular patient that we talked about in the beginning, she did come in confused. So talking about whether they're still confused or if they're now alert and oriented is very important. You also want to talk about their level of consciousness. If you mention to the next nurse that they were alert and oriented, and then the next nurse walks in and finds that the patient is lethargic and confused, they'll know that it is a change in baseline or a change in the previous shift. Now, this patient also has a history of anxiety. If you had to give any PRN meds to help their anxiety, mention that too, so that the next nurse knows that there is something ordered for the patient who may have some level of anxiety. Next is your cardiac overview. Pretty much you're going to mention, is that patient on telemetry? What was their baseline heart rhythm throughout the shift? Are we even monitoring them? Are there any other tests that we're doing that you did in the previous shift? Did you do an EKG? Did the patient get an echo done? You want to mention that in your cardiac portion. Next up is your respiratory assessment. Because this patient came in with a respiratory issue, you may find yourself giving a little bit more information about the respiratory status of the patient. So you want to mention, are they on room air or are they still on supplemental O2? Are they coughing? Is it productive? Has a sputum sample been sent? Are they looking to send a sputum sample? And what kind of interventions did you focus on for this particular system? For your gastrointestinal system, you want to mention all the list of things mentioned here. It's broken up into 2 parts. So pretty much the intake portion and the output portion. You want to mention the diet order. How do they eat? How do they eat? How are their meds taken? if they take them whole with water, or do you have to actually crush them and put them in applesauce? Remember, mentioning these things helps the next nurse be seamless in providing their care. You want to also mention if you are checking blood sugars because that is associated with the diet order. You want to make sure the patient has meals if we're checking their blood sugar and giving them insulin. Then you want to talk about whether they're incontinent or they're continent. This is going to provide the nurse with the understanding of how much care they're going to have to give in terms of toileting their patient. Sometimes if your patient is incontinent, that means you're going to have to give more care to that patient. So you want to mention that they're continent or incontinent. You also want to tell them when the last bowel movement was. Like I've told you guys before, in clinical, we don't generally allow patients to go more than 3 days without having bowel movements because that can lead to a medical emergency. So you want to talk about the last bowel movement. If they haven't had a last bowel movement in 3, 4, 5 days, what did you do for that? Did you call the doctor? Did you give any PRN meds? You want to mention those interventions that you've done. And I didn't mention bowel sounds. The next nurse is going to have to assess that themselves, but you can mention that the patient had hypoactive or hyperactive bowel sounds. So for the genitourinary system, you want to talk about how your patient urinates. Are they able to get up and go on the commode? Do they need a bedpan? Are they continent? Do they know when they have to go, or are they just incontinent? And you want to talk about if they have an indwelling catheter. Bonus points about your indwelling catheter: if you can talk about whether they came in with the indwelling catheter or they got it placed, newly placed during this admission, that's also a bonus piece of information you give your give in report. I say this because, like we've talked about in lab, patients are, if they normally don't have a chronic indwelling catheter, we typically don't like to leave indwelling catheters in. And there is a nurse initiative to remove catheters that are unnecessary. So incontinence is not enough of a reason to have an indwelling catheter. So mentioning to the next nurse that they have an indwelling catheter that's newly placed or a chronic indwelling catheter is important. And never in your shift should your patient not urinate. So if they are retaining, you should talk about whether you bladder scanned, is there an order for bladder scan, and any intervention you had to do for their retention. Next, you want to mention the skin assessment. Your skin assessment might be simple as clean, dry, and intact, no open areas, or if your patient has open wounds or surgical wounds, you want to mention all of the skin issues that they may have. You'll notice that if your patient is incontinent, they may have MASD. MASD stands for moisture associated skin damage, and that happens from just being constantly incontinent. Now, if your patient has a skin issue, whether it's an open pressure wound or a surgical wound, you want to talk about the interventions being done to help heal that wound or protect the skin. If there are specific orders for dressing changes, you want to talk about what the order is and if the wound care nurse has seen the patient. You can also mention things that you're doing for the MASD, such as creams, powders, any ointments that need to be put on the skin. Next, you want to mention the musculoskeletal system. This is basically how your patient moves around. Are they independent? Do they need a minimal assistance, or do they need the maximum assistance of 2 to 3 people? You want to mention whatever type of equipment the patient needs. If they're minimal assistance, do they need a cane? Do they need a walker? Do they get up into a wheelchair? Do you have to use a Hoyer lift? Talk about the types of equipment that you needed to use for that patient that day. You also want to mention any recent falls. This is extremely important to the safety interventions that the next nurse will have to put in place to take care of that patient. Next, you want to mention any lines, drains, and tubes coming out of the patient. This is specifically for your IVs. You want to mention how many IVs they have, what kind of IVs they have, And bonus point if you can mention whether they are a difficult stick or not. That will help prepare the next nurse for whatever intervention they may have to do for that patient, whether it's calling the IV nurse or asking the doctor for a different kind of line. So mentioning all the lines, the type the lines they have, the size of those lines, and the location is very important. Now, any other tubes that are coming out of the patient, you can mention that within that specific system. So if they have bilateral nephrostomy tubes, you can mention that in the genitourinary section. Lastly, you want to mention the plan for that patient. This plan can be found in the provider's daily progress note. This gives the next nurse insight to how we're going to get this patient out. What are the things that I need to look for to intervene for the patient? What are the types of tests that we're waiting for? Being clear about the plan is very important. You also want to mention any time sensitive tasks that the upcoming nurse will need to attend to. So if they have labs they need to draw off the line, if they have any upcoming tests such as CT or MRI, be clear about what the plan is for that patient. And you can also look at the case management note to find out what the plan is for discharge, because the next nurse needs to know what are the interventions I am going to need to focus on to get the patient closer to discharge. So case management note and the provider's daily progress note will give you the plan of care to help that patient move towards their goal and get discharged. Now let's put it all together. You are the night nurse giving report to the day shift nurse. How is this report going to sound? Sandy is a 77-year-old female admitted with left lower lobe pneumonia. She has a past medical history of AFib and is on warfarin. She has coronary artery disease, hypertension, type 2 diabetes, anxiety, and depression. She is a full code with no known allergies, and she lives at home with her husband, Neil, who is her healthcare proxy. She presented to the ED on July 4th via EMS for difficulty breathing, a fever of 103, coughing, nausea, vomiting, decreased appetite, confusion, and weakness for the past 3 days. Her husband states that she is not normally confused at baseline. Upon arrival, the EMS found her O2 sats to be in the 80s on room air, so they placed her on 4 liters nasal cannula with improvement to the mid-90s. On arrival to the ED, she was given 500 ml LR bolus and neb treatment was given to her, and she was started on IV ceftriaxone and erythromycin. She also had a CT of her chest done, which showed a left lower lobe consolidation. So she is here for treatment of pneumonia with IV antibiotics. So the patient is now alert and oriented. She is no longer confused, but she was experiencing some anxiety last night. So I gave her Ativan 2 milligrams PO around 11:30, which had some good effect. She ended up going to sleep, and she can have that every 8 hours PRN. She does have a history of AFib, so she is on telemetry and she is on warfarin daily. Her next INR is to be drawn today at 3 p.m. So I was able to wean her down from 4 liters to 3 liters nasal cannula, but she still continues to have a productive cough. I did send a sputum sample to the lab last night, and she can have neb treatments every 4 hours PRN. I also gave her the incentive spirometer that's at her bedside, and I showed her how to use it. She's going to continue to get the IV ceftriaxone and the azithromycin for the next 4 days. She is on a diabetic diet, but she's no longer having nausea and vomiting, and she's eating her meals just fine. She takes her pills whole with water, and her blood sugars are AC and HS. She states that she's continent and reported that her last bowel movement was 4 days ago, so I gave her her scheduled Colace and Senna, and I did give her her PRN Miralax. She is continent and is able to get up to the commode, so she did get up about 3 times during the night to the commode to urinate. Her skin is clean, dry, and intact, and she has no open areas. She can get up with a minimal assist of one to the commode, and although she's still weak, she hasn't had any recent falls. For lines, she has a double lumen pick in her right arm and a 20 gauge in her left hand. The plan for her is to transition her to PO antibiotics, and hopefully tomorrow she'll be sent home with VNA services um, to her home. This pretty much wraps up how report is supposed to sound. It is clear and concise. It gives all the pertinent details for that shift.